Good morning. I am the Vice Chair of PPACG. Stan Vanderwerth is on his way, but I'm going to go ahead and get us started to respect everyone's time. Thank you for coming this morning and welcome to everybody. It's great to see a lot of new faces and some familiar faces I haven't seen in a while. This is hopefully our first roundtable discussion on senior issues and needs in long-term care facilities. We had an update on what's been going on. Of course, we've all been hearing things, right? And a lot of anecdotal evidence and for the past year, but Jody brought us a letter that he wrote very passionately. Thank you to our last board meeting. And we said, you know, we've been hearing it. Now it's time to kind of see if there's something we can do and put a little bit of our weight behind it. So Jody, I understand you are the one today, huh?
Good morning, everyone. Thank you, Mayor Thompson. I really appreciate it. Yes, so just a little bit of background information. During the February Board of Directors meeting, I shared information, observations from our Ombudsman teams around issues that they have been seeing in long-term care over the years. And it was really kicked off by the incident where the gentleman was found outside of one of our local long-term care communities during a snowstorm. And you know, our goal here is really to talk about the varied issues around long-term care, and just appreciate so many of you being here in the room with us today and those on Zoom. So I will just go ahead and get started. We'll do some introductions and then we'll get rolling. So I want to start with folks around the table first. And then we have some folks on Zoom that I would like to recognize. And then we will get moving into our agenda. So first of all, big thank you to our elected officials who are here today. Many of you are board members, and we appreciate your participation with us with the Pikes Peak Area Council of Governments. Let's start first. As mentioned, I'm Jody Barker. I'm the director of the Pikes Peak Area Agency on Aging, and then we'll move to my right.
Hi, I'm Lori McGinnis. Thank you. Oh, good. Thank you, Andy. I'm Lori McGinnis, the Regional Long-Term Care Ombudsman.
My name is Shannon Lundy, and I'm here on behalf of my mom, who is currently in a long-term care facility.
Thank you for coming this morning. Thank you all. Andy Gunning with PPACG.
Sharon Thompson, Mayor of Fountain, first Vice Chair of PPACG, and also on the Fountain Valley Senior Center Board.
Darcy Shaning, Monument Trustee.
Chuck Shalkowski, I'm a retired detective from the Colorado Springs Police Department. I spent 14 years investigating crimes against at-risk adults, which included facilities.
Robert Zuluaga, Woodland Park City Council.
Roland Gardine, the Mayor Pro Tem Callahan, also on the PPACG.
Thank you very much, everyone around the table. I would like to also recognize board members who may be on Zoom. I see, oh, thank you, Jess. I'm just going to go across the top here. County, go ahead, Glant.
I'm here.
Would you introduce yourself?
Glant Havener, trustee, Town of Palmer Lake and PPACG board.
Thank you. Councilmember Avila.
Hi, yes, I'm Councilwoman Yolanda Avila, and for Colorado Springs, District 4, and also on the board of PPACG.
Thank you. Mr. Donaldson.
So yeah, I'm Dave Donaldson. I represent District 1 on City Council, and I'm on PPACG. And just as a personal note, my father, he developed Alzheimer's in his late 60s, and so he was in a memory care unit eventually, and before that a assisted living facility. So I have a personal experience in this topic.
Thank you very much. I'd also like to recognize some other folks who have joined us by Zoom. And I won't be calling out everyone. I apologize, just due to time and to recognize everyone's valuable time with us today.
Jody, this is
Oh,
County
thank you.
Commissioner, sorry. This is County Commissioner Cammie Bremer, and I am currently in transit, so I'll have my camera on shortly. But glad that I can be a part of this important discussion as well.
Thank you so much, Commissioner Bremer. I do see some folks popping in here, so we'll try to catch others as they come on. Also do want to recognize our state lead ombudsman, Leah McMahon is with us today. Thank you, Leah. I also see Kara Harvey, who is the Director of Aging and Adult Services with the Colorado Department of Human Services. Thank you for being here, Kara. Let's see, I also saw Mr. Chad Fear with CDPHE. Thank you very much for being with us today. Jarrett Hughes is here. Jarrett sits in the governor's office on the governor's cabinet as the Senior Policy Advisor on Aging. So thank you very much for spending some time with us today, Jarrett. Just taking a look through, we have Commissioner Elsner, if you'd introduce yourself.
Yeah, this is Dick Elsner, Park County Commissioner, Secretary of PPACG. We don't have the issues with the centers in Park County because we don't have any, but I'm here to lend any help that I can.
Thank you very much, Commissioner Elsner. We appreciate you being
Jody,
here.
we also have a couple other elected officials from Fountain on the call.
Excellent.
We
Would
have
you
Council-
introduce them
Yeah,
for me?
Councilmember Gordon Rick, who's my alternate, and then in the audience, we also have Councilmember Deidre Duncan.
Excellent. Thank you very much for being here. Appreciate that.
Jody, I'm sorry,
we-
one more quick interruption. Sorry, Councilmember Nancy Fortune from the city of Manitou Springs. Thank you for coming this morning, Councilmember.
Thank you.
Yes.
All right, we've had two recent arrivals here at the table, so I'm going to ask them to introduce themselves. Commissioner Stan Vanderwerf.
Thank you, Commissioner Stan Vanderwerf. I'm the chair of the board here for PPACG, and I heard some people talk about how they're personally connected to this issue. So I am at this point going through some challenges with my mom, who is at present in a senior home, recovering from an emergency that happened to her while she was trying to live at home and was not successfully doing that. So I think everybody knows at one point or another in everybody's life, we have these challenges that take place. So that's why I think this is a great workshop for us to be engaged in and see what we can do better in our community. Thank you.
Great, thank you very much. And to my left, another one of our guest speakers today. Would you introduce yourself?
My name is Caitlin Roseborough. I worked at a senior care facility.
Thank you very much for being with us today, Caitlin. All right. Before I move on, is there anyone else? Let's see. I also want to recognize that we have members of the El Paso County DHS, specifically from the Adult Protective Services Department. So thank you very much for being here. I think we'll have one of your members here in the room shortly. All right, thank you. Is that her? Okay, invite her on up. Sorry, you're on the, you're she's here. Why don't you come up and join us here next? And then go ahead and introduce yourself. There's a mic right there, if you would. Or next to Chuck. Thank you.
I'm Katie Fuller. I'm one of the supervisors for Adult Protective Services.
Awesome. Thank you. Good timing. All right. All right. I think we've caught everyone that we needed to be sure we're introduced. So thank you so much again for being here today. There will be opportunity towards the end for public comment. Due to our operational structure, we do have a quorum of board members, and so it's important for us to operate in a specific manner. I just wanted to share just a few moments of why we're here. So many of you have already shared your connection to this discussion, and we want to make sure that it's a broad discussion. There's no single singular issue, and there's no singular answer. It's important for us to bring all the issues to the table so that they can be discussed in an open and professional manner. And we would encourage you to consider our motto with the Pikes Peak Area Council of Governments is communities working together. And so I want all of us, as we begin to have these discussions, to think about how we can work together to affect change across our region for the betterment of our older adults. And so again, we just thank you so much for taking the time to be with us this morning. We want to share observations. You'll hear a lot of that from those who are here to share their observations. And we want to make sure that we're being solution driven in our discussions. We also want to recognize that our workforce has been a challenge in long-term care even prior to COVID, but COVID and the pandemic has laid bare some challenges even further. We want to also share that the challenges that we as the Pikes Peak Area Agency on Aging have, and that we're not a regulatory agency, but serve as the advocates for residents of these communities. And ultimately back to our solution-driven approach, when we brought this concern and these issues to the board early in February, I'm very proud to say that my staff, Lori as our lead ombudsman, our regional ombudsman, was able to pull together data and observations very quickly so that we could share that. I want to make it clear, although Mayor Thompson was very gracious in her description, I was the mouthpiece. My ombudsmen are those that are living these observations day in and day out. And so many of you in the room see these, live these observations as well. So I want to make sure that we have credit where credit is due, Mayor Thompson. So thank you very much. We're going to start off with Lori McGinnis, our regional ombudsman. And then we will have some testimony from some of our participants today. So Lori, please feel free to go ahead.
So again, my name is Lori and I'm the regional ombudsman. We have about 105 buildings and okay, I'm sorry, I'm gonna sit on your lap.
It's just the people online,
Okay.
the people online can't hear if you're not kind of
Okay,
right in the
okay,
microphone.
Thank you.
Yeah.
Sorry about that. So I am Lori McGinnis, the Regional Long-Term Care Ombudsman, and I want to give a shout out to my teammate, Marky Garcia Miller, who is here in the audience. We cover about 105 buildings with about 4,500 beds in El Paso and Teller counties. So that's a lot of people. I'm gonna, over the course of the last week, I have rewritten what I've wanted to say multiple times. And as I've sat here, I'm going to change it up even once again. So, and I want to start off by saying that over the last week or so, it's come to my attention that when I talk about issues that residents and families and even staff are facing in long-term care facilities, some people feel that I am blaming them. And I want to make it clear that I am not blaming any one person for the issues that are happening to residents in long-term care. It's a systemic issue that is throughout the nation. Lots of people are facing the same issues our region are facing. But I'm just going to speak about our region because that's the region I know. But I just want people to know that my intent is not to blame, only to bring to light the issues that residents are facing. And these are real issues. So, and that is the role of the long-term care ombudsman, is we are direct advocates for people who live in nursing homes and assisted living. Our goal is to help them resolve those issues and bring to light those issues. And in doing so, some people, like I said, feel blamed. And again, that is not my intent. What we are hearing from residents, families, friends, and staff members in long-term care is that residents are not getting adequate care. In fact, in many cases, they are suffering neglect and abuse in the very places that are paid to take care of them. Prior to the pandemic, we had many similar calls, but the pandemic has really amplified and magnified the issues that we are seeing. We're going on 2 years of a pandemic now, and those issues have not improved. They continue to get worse, and it's very concerning. Residents have gone from reporting going weeks without showers to reporting going months without showers. So for those of you who have a morning routine and you get up or you do your hygiene at night, but you think about not having a shower for weeks or months, not getting your oral care done for you. And it's not uncommon for the ombudsman in our region to go into a memory care unit and not see a single staff member in that unit. We have to go seek out a staff member. Residents are languishing in their bed because there's no one to help get them up out of their bed. They sit for hours in their own waste at times. They aren't getting adequate nutrition and hydration at times because there is no one there to help raise the spoon to their lips or the glass of water to their lips. In some cases, up to 70% of staff in buildings are from temp agencies, making it even more difficult for residents to get adequate care because the temp staff do not understand their care plans or what their needs are. Ombudsmen are often asked, so when we work with a family or a resident, we try to work with the staff directly to resolve whatever problems they are having. And prior to the pandemic, we would, with the residents' permission, we would sit down as a team and talk about things and come up with a change in care plan and how to resolve those. And those care plans were often successful. Oftentimes they would have to be revisited months later, but there was movement and change. Now, when those meetings happen, it's usually days later that we're getting a call from the resident and or family that things haven't changed. So when the changes don't happen and families and residents want to know what their next steps could be, we often refer them to CDPHE or if needed, Adult Protective Services and or law enforcement. Oftentimes, it will take months for that complaint to be heard or acted on. And recently, I heard a statement from CDPHE, and this is paraphrased, that they aren't citing for facilities for lack of staff because they are also behind. And there's a real concern about buildings closing. I also heard a statement recently from an APS caseworker that they aren't substantiating all the complaints about staff that they could substantiate because there are concerns about impacting the already strained staffing situation. The fear of nursing homes and staff leaving is a very real concern. I've heard an owner of a facility tell me that they were doing the best they could just to get a body in the building. I believe that many of the people who are still working in the facilities are really doing the best they can in a very broken system. But that does not mean that those of us who have oversight of regulations, safety, or resident rights can pick and choose the regulations we get to follow. My goal today, my hope today, is that we, meaning regulatory, APS, law enforcement, facilities, and the community in which these people live, find a way to come together to stand strong to ensure the well-being of people who live in long-term care. Because I could talk about these issues for a long time, but my time is limited. So I'm going to suggest to you, if you would like more information, to please go to the National Consumer Voice website, and they will have documents there that talk about staffing issues that you can look at. There's a lot of information on that website. I want to thank you sincerely for all of your time to hear not my voice, but the voice of the residents, in which we are all charged with supporting. Thank you very much for your time.
Thank you, Lori. We'll now move into some testimony from some of our guests. Lori, would you introduce your?
Excuse me, before you start that, could I just ask you to give the website that you referenced for that resource?
Sure, it's the National Consumer Voice.
And where specifically is it that?
I don't.
That's fine. If we can have it posted, maybe Jessica can post it on, that would be fine. Yeah.
She gives you the thumbs up. Thank you. Thank you.
All right, thank you.
And so with me today is Shannon, and her mother is in a nursing home, and she is going to talk a little bit about her experience and her mother's experience.
Hello. I feel like Lori already touched on a lot of pertinent information that does specifically pertain to my current experience. My mom suffered a severe stroke. I'm sorry. I don't speak well in public. And she's been in a facility for about 4 months now. And without elaborating extensively on all of the situations there, but there have been multiple situations of neglect or even incompetence to some degree, very poor communication. My mom has been hospitalized 3 different times, all for what I see as preventative situations such as severe or multiple urinary tract infections, pneumonia, wounds on her bottom, severe dehydration. She is high risk for aspiration and cannot swallow or eat. So she's on a permanent feeding tube. So she needs to sit elevated at a certain degree. And I do believe that, I find her lying flat pretty frequently. And that's been a major concern I brought to the facility's attention with the high risk of aspiration. She requires oral care several times a day to prevent saliva and bacteria from trickling into her lungs, since she cannot control her swallowing function. And her oral care was so horrible. I don't even know that she had received any oral care for quite some time before she experienced a severe gland infection as a result and was hospitalized for that. I do agree with Lori that they're understaffed. I do empathize with them not having the proper support in those facilities to better manage and take care of patients. However, I also am frustrated with just the basic level of care that is not being received, just the monitoring, vitals, oral care, even bathing. Some of these things being overlooked or not done could be very detrimental to certain patients, such as my mom, causing infections that could be life-threatening. I don't really know what else to really touch on, except that it's been very challenging for my family. It's basically been like a second job for me, because I have so much anxiety of making sure there's eyes on her every single day to make sure that she's getting the proper care that she needs. And again, the bare minimal, let alone some of the preventative things that she should be receiving based on her medical needs. She's experiencing depression. She is currently pretty much bedridden, requires 24-hour care. But I found her sitting in a wheelchair 9 hours, not changed. She had already had an existing wound on her bottom. Again, severe dehydration. She can't hydrate herself. So obviously someone has to do that for her. The UTIs, and again, I've already said those things, but there is a level of negligence, in my opinion, as well as some incompetence that exist in these facilities. I do believe there are people there who are passionate and want to enforce change, but they obviously need a better support system to do so. I don't believe they should be taking on additional patients if they don't have the capacity to care for them properly. And the communication has been very, very challenging for me, especially, no follow through. I'm constantly being redirected. I'm having to make them aware of my mom's physical changes, and hasn't been really any urgency or initiative on their part. When she has been ill, I've initiated all 3 times that my mom has had to have the EMTs called to the facility, and all 3 times she was hospitalized. And this most recent was 10 days long. That takes a toll on her as well. She's still trying to recover from her stroke. She can't communicate very well. So I have no idea if there's, concerns that she herself is experiencing and she's unable to articulate that to our family. So that's another area of anxiety that we experience. I don't know what the fix is, except I wouldn't take on more patients if you don't have the staffing to properly support those patients. And again, the basic bare minimal isn't even being done, let alone the extra preventative measures that she needs, and I'm sure plenty other patients. And so it has been a very trying experience. We have involved Lori. We have involved Adult Protective Services. Colorado Springs Police Department has also been involved. We currently have her on 3 waiting lists. The social worker at the hospital is actually the one who initiated involving authorities or these other resources, as they're the ones who had seen her 3 times in less than 3 months with these different, health situations. And also I had expressed my concern of her returning to the facility. Unfortunately, she is back at the facility because we don't have any other choice at the moment. And I don't know, and Lori and I had this conversation, if moving her is even the solution either, because if this is a worldwide concern, I don't know that she will, have a different experience somewhere else. But I guess my goal is to just bring awareness and be an advocate for my mom. And my heart hurts for those who don't have anybody to speak up for them. So I'm hoping we can find a way to fix this broken system. Thank you.
Thank you so much for sharing today. That's very difficult for you. We recognize that. And thank you so much for being here with us. I'd like to turn now to Caitlin, if you would. Thank you very much.
I'm going to get emotional too, so I apologize in advance. I was asked here to come speak. Thank you. To come speak about my experiences at a long-term care facility and the concerns that I do have. Sorry. Oh, there we go. The barriers that I faced while working understaffed, the health and safety concerns about the residents, the lack of communication within the management. I know it is very common right now to be short-staffed with resident assistants, QMAPs, and just directors and anybody. And it is really heartbreaking. They won't receive the full attention that they need with a short staff. It's like, I'll just spend 1 minute here with one resident and then move on to the other one. And that's not fair. They need more than a minute, but that's all the time we feel like we have. Apologize. And like what Lori said with the temp agency, they would come in, some were great, some fit in with the facility's protocol, meshed well, and then there's others that got a paycheck at the end of the day. They are not as passionate as some of the caregivers that I know. We would leave our shift that day, and we knew like the evening shift, they wouldn't put in the work that the morning shift did, or the overnight. People were getting caught sleeping. They weren't doing 2-hour checks, 2-hour safety checks. And for one resident's family, they had enough. They put a camera under her bed because they did not believe, and it was true. They were not coming in every 2 hours to do her safety check, and she would lay there, and it was, and you walk in her room, and it was just so heartbreaking to just see this resident just laying there, not getting assisted for feeding or drinking. They were all very dehydrated, and I get really emotional when I talk about the memory care residents, because some don't know how to speak up for themselves, and they can't say what's wrong. But the caregivers that know and that are passionate about every single part of this career, we want positive change. That's just, at the end of the day, that's all we want for our residents, is just care. And it's very hard to find. And with that family, they actually did a welfare check and moved their family member out as soon as possible. And it was sad to see her leave, but we knew it was a lot better. She was going to get the care she needed, and she wasn't getting it at this facility that I was working at. I've told and I've explained my concerns to management. It was constant. It was one thing, at least I would have to talk to a director about, and sometimes I would get nowhere, and I would have to go to the executive director, and all she told me was, things will get better, just give us time. And in my opinion, that wasn't good enough. The director did not understand or see what we are seeing, and that was frustrating. And I felt I had no support system, and it was a David and Goliath situation. And fighting for changes, it is very hard when you have no support. And then Miss Lori came to my rescue, and now we're just expressing the concerns in the long-term care facilities, and there are a lot. And coming from an employee, things need to change as soon as we can, because it is going downhill, and you can see it just in the residents' eyes, and it's very sad. And it's very heartbreaking, and I wish I could do more in my shift. Sometimes I would pull the double, because I knew the employees that were working that night and the agency, and I knew they were gonna provide just basic care, and management wasn't helping. And so some of the employees just stepped up and tried to get things done as quick as we can. And sorry, it was just a fight every single day. It was stressful, and there were so many issues people in management were ignoring, and especially in memory care. And I felt it was just the last thing on their list because they can't advocate for themselves. And I was just shocked at this facility. I was taken back. I was questioning how people could work in a career or a career like this and not want to do more. I guess that was my confusion with the directors and management. Why aren't we doing more? Why are we not taking steps for positive change? And it was hard. It was very hard. And same with the safety concerns. It was biohazard bags with COVID. We would have to go into a COVID positive residence room, and the overnight shift, I was a morning shift. I got there at 7 a.m. and I would see biohazard bags in the hallways, not even tied. They're just wide open in the assisted living area or wing, and just wide open, just in the hallways, not being thrown away appropriately. Even we had one, but people weren't using it. I didn't understand that because there were signs. It was just negligence, honestly. At the end of the day, I don't really know, but it was just another fight. I would again go to the chain of command, and I would get nowhere. And so me and the employees, we just took what we could get and we made it work, and as best as we could. It was nobody. I felt like nobody was taking accountability. I would help, me and another employee would help take out the trash at the end of the day, because the director that used to do that, he already had a lot, again, being short-staffed. We did what we could to help. I felt we were a team, and I was proven we are not. Or at this facility that I worked with, everybody was just out for their own, or like the paycheck at the end of the day. When me and the other employee were getting trash in the office, there was 2 positive COVID tests in their trash, and we have a place to dispose of all COVID tests. So I was very confused why there was COVID tests in an office trash can. I brought that to an employee that was in corporate, and she said, "Oh, I know, let's just not mention it." And that's when everything turned. I used to have care meetings with families, and they knew me very well. You could give me a room number and I could tell you who the resident was, maybe some little fun little facts about them. But the big thing that I faced with, and this broke my heart. In memory care, there was a sewage line break, and it's, I guess, been a problem. It keeps overflowing with feces and mud. The smell went to the other side of the building in assisted living. I didn't understand because I was still fairly new. I didn't understand, but then later found out it was this sewage line break. And my heart dropped when I saw this bathroom. There was a plant growing in the toilet bowl. And what was so heartbreaking is sorry, I love this resident. There was a resident living right next to this bath or this other apartment, and you can see it just being soaked into the wall, the floor, and they didn't move her. They didn't move her, and I didn't understand why. So like I said, things we gotta change something because this is just not okay. It's disgusting. It's not even human to treat another human like that, I feel. And like I said, memory care residents I am their advocate. I chose, and I'm here, and I'm making the steps for positive change or any change. And then a few days later, after I found out about this sewage problem, memory care residents were getting tested for C. diff and a neurovirus. For what little thing, I do not know, but I do know that they were being tested for that. And in the end of January, on the other side of the building, residents were also getting sick with the same symptoms as memory care, and they're on opposite sides. I wish I could do more.
Thank you for
Yeah.
being here today, Caitlin. It's obviously very difficult to witness that and
Yeah.
experience that. And so we appreciate you taking some time this morning.
And they're not
to
following
share.
CDC guidelines.
Thank you. Thank you very much. As we noted before, these are observations that we're sharing and bringing people to be able to share these observations. And so we, again, want to thank those who are here to share. We have folks from Adult Protective Services who we've asked to share some observations. I believe, is it Eric? So Eric is on, Eric Bidwell is on Zoom and will be sharing from Adult Protective Services.
Good morning. Thank you, Jody. My name is Eric Bidwell. I am a manager within DHS. I oversee the Adult Protective Service unit here in El Paso County. And there's definitely some kind of coinciding challenges that we've seen as it relates to facilities, certainly from a staffing level, and just the challenges that they've had going into facilities and not seeing individuals, or there being one person trying to kind of cover multiple things. I'm going to let Katie kind of speak to that more specifically in just a minute. But what I do want to point out is a couple things. One is that, our office, the Adult Protective Service office, is essentially created as a reactive kind of investigative department to look into situations where individuals are being abused or neglected, whether at home, in facility. That is the location is irrelevant. It kind of goes back to that abuse or neglect. And I only say that to say that we can only investigate information that we're aware of. And so there may be situations where, someone is potentially in a situation where they're being harmed. But if individuals aren't reaching out to us to let us know that, or to make us aware, either by reporting directly to law enforcement and it getting to us, or reporting directly to us, it kind of limits our ability to be able to intervene or advocate on the behalf of the individual in those circumstances. And so sometimes that is a bit of a limitation. The other thing I would say as it relates to, I know Lori mentioned earlier, she talked about a caseworker making a statement as substantiating on a perpetrator. I think potentially what is being referenced there is that in our statutes under caregiver neglect, it specifically says that an individual, when we're looking at whether we should substantiate on a case based on what information we may have found, we're supposed to take into consideration what a reasonable person would do in the same situation. And so when you have a facility where there's one person that's trying to run, way more than what they're supposed to, we have to look at that situation from the standpoint of, is there anything that this person could have reasonably done more than what they did, And certainly in some situations that could be the case. We definitely, maybe there is more when you're referencing individuals that are sleeping on the job or not doing just the basic, kind of checks that they should be doing. That certainly is not outside of the realm of reasonable. But if you have an individual that is doing the best they can and trying to meet the criteria, trying to, meet the statutes, the mandates, trying to fill the gaps wherever they're able, we also, don't want to punish a person for a systemic issue. And so that's the way the statute is written, is that, we're supposed to look at it from the perspective of what would a reasonable person do in the same situation, and what kind of judgment would they exercise, what kind of decisions would they make. And so that potentially can seem as though we may not be substantiating on a situation where potentially there was some sort of impact to an at-risk individual, but we're kind of looking at it from that perspective. And is this something that a reasonable person in the same situation would have done differently or could have done differently? So I just kind of wanted to point those two things out. We definitely, I will also say that I think since COVID, because individuals in this realm are often extremely isolated, just by nature of being in a facility, and through COVID have been even more isolated, we're not seeing the same level of reports. We're not seeing the same number of reports. We're not seeing the same, variety of reporters, because unfortunately, not as many people are having eyes on these individuals as had been in years past. And at the same time, when we do get those reports, oftentimes the severity is significantly higher, because instead of it having gone a couple weeks where things have maybe slipped and we need to become involved, it's gone months before somebody has noted that there's been a change or a difference in this individual and in the living circumstances. And so although our number of reports has gone down, the severity and the significance of the reports has gone up, because when they are being reported to us, they're often of a much more significant nature. And so those are the couple things I wanted to point out. I wanted to give Katie a few minutes to give any additional insight that she's seeing. We do have our lead workers actually specifically doing facility type investigations. So they're individuals who are highly trained and people who have a significant amount of experience in APS. And so Katie, if there's anything additional you wanted to relay, I wanted to give you a chance to do that.
So up until about 2 months ago, I actually was the lead caseworker. So I was going out and doing the facility investigations. I also have a medical background. So I'm a caseworker who can go out and review medical charts and know what I'm looking for with documentation and things like that. I will say some of the things that Kim and I, who's the other lead, have struggled with is doing that substantiation on a CNA or a nurse who is showing up every day for their shift and doing the best they can under limited circumstances. So we did actually reach out to state about that, because when we do a substantiation on somebody, it's going in our system and it's going to jeopardize a future job with them. So we wanted to figure out, how do we do this and make sure the residents are taken care of, but also make sure that staff who shows up every day doing the best they can is not getting penalized for showing up and doing that. And so state was actually the one who said a reasonable person, make sure you're reading your definition. So it's actually had Kim and I kind of take a step back to relook at that definition, because granted, we know there's bad people, bad employees everywhere. We 100% understand that. Not everybody's perfect, but you have these employees who are showing up every day doing the best they can, but we're going to come out and we're going to substantiate on them because they were the only ones there that day and couldn't take care of every single resident or bathe every single resident. So that's where APS has stepped back to look at that substantiation level and look what we're looking at. We have seen the turnover and what goes on. I mean, sometimes I've been with APS 6 years, almost 6 years, and you'll go into a facility and those CNAs were just at that facility and now they're at this facility and they're over there. So that's always been kind of a thing that's gone on. But I would say, I agree with Eric, we don't know if you don't report to us. And that is something that we've had. Also, APS, we have a system that we have to follow as well. So if we're going out and it's really, really bad now, but we're just getting the report, we still have things that we have to investigate and follow up and find out what's going on. So where the situation has been bad before that, we're just now getting involved. So we ask that you work with us and help us out. And there's going to be information that we need as well. Also, when calling in a report, one thing that we have kind of noticed is we're not getting a lot of the diagnoses that we used to. So if you're calling in a report to us as a mandatory reporter, please let us know what that client, we call them clients, or that patient needs and what they need help with, because that also helps us decide what to screen in, what not to screen in. So if you're just telling us that somebody's elderly or frail, they might not meet our criteria. So we need to know exactly what their medical diagnoses are and what they need help with. The more specific of a report you can give us as to what's going on also helps us to decide what needs to be screened in and screened out. So details are very, very specific. I think we've kind of noticed that in some of the reports, we're not getting as much detail as we used to. So the more detail, the better. And that also helps our caseworkers to decide what approach they're going to take when they go out. So Eric, did you have anything else?
No, thank you. And Jody, I appreciate the opportunity to be able to speak and to be able to be present. And so I think that's all we have for the time.
Great. Thank you very much, Eric and Catherine for sharing today. We appreciate your time.
Jody,
And,
you have
again,
a hand raised over there.
Yes, sir.
Okay, I'm Roland Gardina, Mayor Pro Tem Callahan, but I've had some personal experience and family members, but what is the timeline? Okay, but time that you're already talking about a month before the report comes in, but then there's action taken and there's actually satisfactory results. What is that timeline?
Yeah, so when a report is made to APS, that information is, so every report that's made today, there is a screening decision made tomorrow on that report. And so it's either determined that we're going to screen it in, which means we're going to go out and investigate kind of what's going on with the situation. Or if for whatever reason the report is not screened in, typically because either there's not a mistreatment that's reported, which is relatively rare, but more because there's not an at-risk adult based on APS definition. Then if it's screened out, there's nothing else that we would do with it. But if it's screened in, typically that information is investigated. Someone is going out to see that individual within 2 or 3 days. And so I would say the timeline is anywhere from 3 to 4 days from the time the report is made until we're actually seeing face-to-face with that individual. And then as we're gathering investigative data, depending upon the severity of the circumstance, we're going to take action as quickly as we can based on what information is reported. So if it's a severe situation, that 3 or 4 days upon that initial contact, we may be taking action right then and there to say, hey, this person needs to go to the hospital. This person can't be here. The situation is unsafe, whatever that may need. The month is how long it takes us to gather all of the information and put together, here's what we're creating as a finding. So we've gathered enough information now we've talked to all the sources, we've talked to the clients, we've talked to the professionals involved. we have all of the information together, and now we're making that finding on this case. That typically takes roughly a month. But for initial action and reaching out to the client themselves, that's usually only a few days.
So you're saying that the patient's at risk for 2 months before then things are completed? Is that what am I
No,
hearing?
what I was saying about the monthly was with the reference of, sometimes things aren't being reported to us, like we knew something was going on a couple months prior, but APS isn't getting it yet. So once we go out, we do respond, and we do respond. We also can respond with an emergency and have a caseworker go out that day if that immediate risk comes out. Now, when we go out, we're not doing anything for the client in that time. Absolutely not. We can go out and we can offer services and we can get things set up. However, if we go out and a client doesn't want our help and doesn't want our services, we can't force those services.
Okay.
So I think it's a little bit different than child protection, where when child protection, you go out and there's immediate risk, they can intervene and a judge can come in and do that right. We don't have that authority with adult protective services. Now, if we do feel that somebody doesn't have the capacity to make that decision and that they are struggling and we need to intervene, we do have what we can do, an emergency court hearing and get in front of a judge and say, hey, we need an emergency guardian to help make choices on this. That is something that we can do, but there are steps to that. We have to have that reasonable and knowledge that they lack the capacity to make a choice for themselves.
So are you establishing a medical treatment plan when you go out there with the investigation?
So we don't do medical treatment plans because we're not medical staff. So what we do is we look at the resources that need to go in. If they need home health care in, we contact home health care agency. We work with their primary care doctor to get the orders, to get the home health care in, and we put the resource in place is what we do.
All right, thank you.
And if I might just maybe add a couple of things, because we're going to probably get down to some conversations about resources eventually here. So the Department of Human Services that these folks are from is part of El Paso County. They've got over 600 people in that office. You might be able to give me a better number, but I know it's at least 600. I think 350 of them are caseworkers.
For adult protective services, we actually our adult protective service unit is a staff of 13.
Yeah.
And that includes supervisors.
Yeah, but the total DHS are these kinds of numbers. And there is an adult abuse and neglect line that you can find on the website. I'm just going to give the number now because it should be a matter of public record in this forum. And that's 719-444-5755. Do I have that correct? Okay.
Yes, sir.
And there's a lot of other functions that the county
What were the
performs.
last four numbers?
Oh, yeah, sure. 719-444-5755. And if you don't get the number, you can just look on the internet, Department of Human Services, El Paso County, and you'll be able, they have their own website, dedicated website, and you'll find all these phone numbers on there.
Jess has also put it in the chat for those of you who are on Zoom, if you missed that. Mr. Zualaga, you had a question.
I do have a question for you, Eric and Katie. So it sounds like you go into these cases, you'll get them. It sounds like you're getting less of them. And when you get them, they're more intense. Do you work at all with the Department of Health? Do you work at all with building code? Are there standards that these facilities are required to have, inspection cycles that keep the standard so it doesn't deteriorate to, it sounds like what Caitlin's experience with the sewer unchecked in a building for sounds like quite a while. Is there, what part does that play? I mean, if the likes of Caitlin are doing their best, you come into it to inspect abuse, seems to me it's more structural, it's more it's just systemic, and with what the owners of these facilities are being set to or not.
Yeah.
No,
that's a,
please.
I was gonna say, yeah, that's a great question. And I'll kind of answer the question that I saw in the chat as well from about just kind of what do we do if the staff members, we see that they were doing the best they can, but maybe it's an owner or it's an actual facility issue, like at a larger level. So first of all, yes, we do work with the local building code officers. We work with CDPHE, make reports to them. We work with the Ombudsman program as well to kind of coordinate when we're able to do that. And it's a situation that kind of crosses both borders. Ultimately, what we're doing is we're looking at what the standards are. So we're looking at what the care plan is for this individual. We're looking at what is the care requirement for this person? Are they getting that level of care? And if they're not, who ultimately is potentially at fault for that? So that's broadly, that's kind of what we're looking at. That does mean that if we look at a specific staff member, so let's say, this person was the one that was actually on shift at this time when this incident occurred, but we, through our digging, kind of find out, the staff member was, as we talked about, is maybe doing the best that they can under the circumstance and with the training and with the information they were given. But what we find is it was actually a faulty training, or it was a faulty, decision made by administration, made by the owner, made by the person who's running the facility. We can then add them potentially as a perpetrator and substantiate on them as a person. We do not have, state APS, we do not have the ability to substantiate on a facility. So we can't substantiate on an organization. It's tied specifically to a person. And so when we're looking at, and as we go through the investigative process, part of our role is to look for, are there other perpetrators that exist that we just didn't know about initially when we got this case? And so through that process, we could determine, oh, the owner is actually the one that they didn't properly train their staff. They didn't have enough staff. They didn't, whatever that looks like. And we may then, and have in the past, substantiated on the owner themselves. That also stems to, well, maybe it was the shift leader that day didn't, ensure that individuals got what they needed, or didn't ensure there was enough staffing, or whatever that looks like. So we do have the ability to kind of, look for those individuals, but we are not able to substantiate on an organization or on a group broadly. We have to find a person to do that, which is where then we come back to that reasonable, what's reasonable for that person to have done and or not done in the circumstance. And so we do work with a huge amount of community partners and resources to kind of make referrals to other entities, and or even go in. Like, it's not uncommon for us to go with building code at times, particularly if we're talking about like maybe someone in their home kind of situation, to try and help correct whatever may exist. But in those situations where we see major things that are going to be like hazardous, or things that are going to be communicable, or that kind of stuff, we would absolutely reach out to those community organizations to get them involved as well.
Yes. Are you about ready?
Yeah, I'm more than ready.
Okay.
I'm chomping at the bit.
All right. If I may, I just want to make sure we have an opportunity for Katie and Eric to close out. Are there any other comments that?
I see another question in the chat that I was.
Yeah, and that's from one of our board
And,
members, Yolanda Avila, City Councilwoman. So
Yeah, I just want to clarify real quick. Mary, there will be open, this is for Mary Kep. There will be public comments here in a little bit. So if you'll reserve your question for the moment, I would appreciate that. Thank you. Go ahead, Katie.
So I will say, when it comes to the owners and facilities, one thing that we have started looking at, and the other lead and I actually talked about this yesterday, is we want, at what point, if it's a staffing issue, are we assuring that the facilities are trying to hire people? So that is something that has been brought to our attention, and we are looking into that as well. As like, do we need to ask, hey, are you actually trying to get people in here? What are you doing for your employees and things like that? So those are steps that we are taking as well and looking into. So yeah, unfortunately, a lot of the accountability does go to the staff that's on that day. That's why I know Chuck and I have done several facility investigations together, and we ask for the training logs. We want to see how the training's been done. And if that's an issue, then that's when it escalates up. So if a staff member hasn't been trained properly, we do look into that. And then we also do request, and APS doesn't really require, we can't do that, but that they do some new training, and we have asked that they send us those as well. So I've gone out on facility cases where I have said, okay, they said, well, we retrained, and I'll say, okay, well, show me that. And so they'll send me the presentation they did, the employees that attended, things like that. So we do follow up on the training if we do think it's an elevated issue where somebody was not trained properly to begin with.
Great, thank you very much. I would like to go ahead and introduce retired Detective Chuck Schakowsky from the formerly from the Colorado Springs Police Department. We did invite the gentleman the detective who came in behind him, but there was a training today, so he's not available. And so Detective Chuck has made time for us this morning. So I'll let you ask your question or comment, and then just go ahead and roll into your observation.
Thank you, Jody. Yeah, I just want to make it clear. I've been retired for almost 2 months now, so my comments do not represent the opinions of CSPD, but they're based on my 14 years of experience investigating a lot of cases at facilities. I'm sitting here boiling because I hear all these questions. And just to give you a little background, Colorado instituted mandated reporting in July 1st of 2014. So if a person is 70 years old or older, they're considered automatically at risk. And people that work in facilities, provide care, they're mandated reporters. And if the stuff that we've heard described here, the conditions at facilities, both from the family member, from the ombudsman, and from the former worker, all reach the level of mistreatment. And the law says if you witness mistreatment, have reasonable belief that somebody's been mistreated, or that they're at imminent danger of mistreatment, you must notify law enforcement within 24 hours. So that goes back to the issue of time lags. It's a month before APS gets notified. Well, if you're following the law, because if you fail to report, it's a class 3 misdemeanor, and you can go to jail for 6 months and have a $750 fine. So if you're following, which as a mandated reporter, then you're getting that report sooner. And just to let you know, and when I say we, it's just because I still haven't made the transition out of CSPD, but we have a system set up. The law says we have to notify APS within 24 hours. We have a civilian criminal investigator in their crimes against at-risk adults unit at CSPD that nobody in the state has. Her position is funded half by the police department, half by APS. We get every call. There's a way for officers to identify in our databases every call for service that includes an at-risk adult, and we have an alert for every facility. So we see every call that involves an at-risk adult and every call at a facility every morning. We review those calls every morning with APS and decide if it's theirs, ours. If it's both of ours, then we do the joint investigations that Katie and I have done for a long time. You've heard about staffing as the #1 issue. Staffing's always been an issue. COVID just exasperated that. Eric's talked very well about it. It's a systemic issue. So how can I charge a CNA who are a nurse that's doing the best they can when there's just not proper staffing? So we do work very closely with Colorado Department of Public Health and Environment. We routinely send complaints to them. They are facing the same problems that we have with staffing. And so sometimes it takes them 6 to 18 months before they can respond to a complaint. And by then, the staff's changed over, different directors are over. We have closed, I worked with CDPHE and we closed 3 facilities in El Paso County in the time that I was on with CSPD because of not following the regulations. And just to let you know, when they instituted the law in 2014, and just so everybody on a statewide basis understands what's going on, because I always got calls from smaller communities. The law said, first off, it didn't give any other money to law enforcement. It says you're going to take on this responsibility, but we're not going to give you any money to fund these positions. CSPD created an at-risk adult unit out of their own pocket. Eventually, Denver and Aurora have done the same thing. But right now, those are the only 3 departments in the state that I'm aware of have units that specialize in this. And the law said every law enforcement agency in the state must have 1 person who has attended this special training that put out by Colorado Post for training on law enforcement officers. There was nothing in the law on how to continue that training or requirement to continue to have a person trained in that area. So you can imagine what's going on at the smaller agencies. I would get calls when I do presentations at the state level and the national level, And people would approach me and say, you know, we called our local law enforcement agency. I have this situation going on at the facility and they don't want to hear about it. It's because they don't understand what the law requires. I mean, the issues that we see, to me, it boils down to three places of inadequacy: staffing, which has always been an issue; supervision, inadequate supervision by DONs, NHAs, the mom and pop small assisted living. Assisted living has a lot less regulation than skilled, and they don't go out at 2 or 3 o'clock in the morning to see what's going on, to find the staff sleeping like we've heard about, or see what's going on in the community. I tell people, if you're going to place somebody, don't schedule a tour. Go after duty hours when the DON and the NHA aren't there, the nursing administrator, home administrator, or the director of nursing, or go on a midnight shift and see what's really going on in the facility. I mean, my dad had to go into hospice in 2004, and he had to spend one night on a Alzheimer's ward before a bed became available in the hospice facility. I'm talking to a nurse who's in an Alzheimer's facility, and he tells me, I like working here because these people don't know what I do and they can't report it. So that was a big red flag right to me. That guy was fired the next day after I talked to the administrator. So supervision, CDPHE does what it can within its limited staffing. They need more staffing so they can respond more quickly to reports, and so they can just do what they have to do as far as what the law requires for surveying facilities. They just don't have the staff to do that. Inadequate training. We heard of memory care. Katie and I will get the training records. There'll be a stuff initial off. It's all paper whipped. We go to a memory care unit and they don't get any specialized training on how to deal with people with dementia or people that have mental illness. You know, some of them must say, well, here's a video from Tifa Snow, go watch that, you know, because she's supposed to be an expert on how to talk with dementia people. But they really don't receive the training that they need to deal with any of these populations. Most people with dementia also have mental health diagnoses because they go together, but the staff is not trained on how to do it. I could probably take up the whole meeting with my 14 years of experience, but we heard about 15-minute and 20-minute checks. We often get a response from this facility, oh, we put the person on 15-minute checks. We put them on 30-minute checks. We put them on 2-hour checks. That's just paper. It never happens. There's no way, nobody supervises to make sure that really happens. There's no way that they don't document it anywhere. And if they did, it's just pencil whips. And I can say that because I've investigated cases where a resident was injured or died. And when I got the documentation, it showed that those checks were completed after the person was in the hospital or after the person was dead. So, you know, so that goes back to the oversight and supervision. People complete their charting at the beginning of the shift, and some nursing home administrators and some DONs know that. And so they can say, they can go home on time and it looks like they did everything. But then when something goes wrong and APS and I get involved, we start investigating the case, and we'll interview the person. And I say, well, I really didn't do that. You know,
they can't remember if they went back in even after they had documented it.
Yeah. And there was no system in place to make sure that they were familiar with care plans, especially when care plans change, our medication administration records, when those change. There's no system in place to be sure the staff does that. I was married to a nurse for 45 years. I know that, you know, they're supposed to do a report at every shift. Talk to most of the facilities. There is no report between shift change. The Union Printers Home, when that lady went out and was expired outside due to exposure, they had a policy in place that said you were supposed to do walking rounds and put hands on, face on every resident. That investigation showed that was never happening. Nobody was enforcing those policies. So you have policies that aren't enforced, or you have policies that are very vague. We've had the potential between the bridge and another facility for 3 more incidents, just like we had at Union Printers, where a person was left outside exposed to the elements. Fortunately, they survived, but investigating those things, you talk to the director and they say, oh, our policy says that. Well, let me see the policy. Their policy doesn't say that. It doesn't fix responsibility. Or they have codes on the door to prevent staff from people from going outside, but they don't have an individual code for each staff. Each staff uses the same member. So you can't tell who opened that door and left it open so that the person can get out. So those are the kinds of things. And you go back to when we want to charge, who do we charge? And many times that's why we can't, because it's systemic. You know, I have to prove a specific person failed to meet their responsibilities, just like APS. So that's where, you know, that's it. Like inadequate background checks. You know, they only go back 7 years. I've done criminal investigations and found that I have a convicted felon, a person convicted of crimes against at-risk adults, either mistreatment or exploitation, working in a facility because they committed that crime 8 years ago, 9 years ago.
Jody, if
Thank
you
you,
might,
yeah.
if I could just ask the question, because we did post the phone number for Adult Protective Services out of DHS. You've mentioned that there's actually a legal obligation for someone that identifies or thinks they see abuse to report it and to report it immediately. So how would they get a hold of the Colorado Springs Police? What's the number, or how
To
do
get a
they?
hold of Colorado Springs Police, your initial response is going to be by a uniformed officer. One of the detectives is on call, and there's certain cases that their sergeant will send them out on, but your initial response is going to be a uniformed officer. You call 719-444-7000, and that gets you to our dispatch, and they will send it out. The statute says you notify the law enforcement agency with jurisdiction. So if it's outside of Colorado Springs, then what you notify is the El Paso County Sheriff's Office at 719-390-5555. That's a non-emergency dispatch. And they dispatch not only for the sheriff's office, but for all the smaller law enforcement agencies in El Paso County. 719-390-5555.
And if you're not sure who to call or what jurisdiction it is, if you call Colorado Springs Police Department, they will guide you and transfer you to who you need to call.
We have a new system between, we again, CSPD and EPSO have a new system in our dispatch where if it comes into us and it's an El Paso County call or vice versa, that is transferred between our dispatch centers. So we don't tell you to hang up and call EPSO. We take care of that. Or they don't tell you to hang up and call CSPD. It's taken care of internally.
Thank you, sir.
Yeah, thank you. Thank you very much, Detective Chuck.
You guys are talking about reporting, and I totally agree with that. I really do. But this facility that I was working at, we had a compliance hotline that we would have to call. I'm still waiting for a call back that I made in January. We were told to go through management. When surveyors from the state came in, we tried to tell them and nothing. And then corporate came in, and then we were given another number. It's a employee safety commitment number. They wanted to keep it in-house. That's how I just wanted to let you know.
I
We
understand
did
that,
try.
and that's what when I was a detective, APS and I did joint trainings, mandated reporting to professionals and to many facilities. And the important thing is to understand, as an employee, I understand that they have internal procedures because they know you need to notify CDPHE all through the portal and all that stuff. But the law says you have to notify law enforcement within 24 hours. So, and we stressed in our training to facilities that company policy, facility policy does not trump the law. The law, if they want to sit by you when you call law enforcement, fine. But they can't stop you from calling law enforcement. They can't retaliate against you for calling law enforcement. And I've had people that tell me, well, we wanted to complete our investigation first to determine if it was criminal. You're a nursing home administrator. You don't determine if there's elements of a crime here, so.
And
Too, that it's not your job to decide if it's criminal. That's APS and Chuck's job. APS doesn't even decide if it's criminal. So we have a different policy that we follow when we substantiate on somebody. When I substantiate, to sum it up, basically you're guilty by APS standards. But to do that, we have to only have a 51% preponderance of evidence for APS standards. Law enforcement has to have unreasonable doubt. So that's where you have two different entities going there. So where we may substantiate on you with an APS case, it doesn't necessarily mean that law enforcement is going to be bringing criminal charges. There are two different ways to look at that as well.
Thank you very much. I
And
want
I
to
apologize
recognize.
for my emotions. but
That's-
you can tell I've been passionate about this. So,
Yeah,
appreciate
and
it.
recognizing that our promised time, I do a couple of things I want to recognize, and then I'm going to pass it on to our chair, Mr. Sanderworth. First of all, this is not the only discussion we plan to have. This is just the first. If you came today to share public comments, we encourage you, send me an email if you like. Jess, would you put my email on the in the chat? It's jbarker@ppacg.org. Thank you. It's on the screen there as well. I also want to recognize those who have shared today. It's a big deal, and it's we understand the toll from both the family perspective and the staffing perspective, as well as APS. You have your laws and specific language to follow, and we understand that it's very challenging. Sometimes what we want to do is not what we can do, but yet we appreciate all of you have come. And Detective Chuck, I appreciate you taking some time out of your retirement to come and visit. We know you're staying busy, and we appreciate your time. For now, I'm going to hand it off to Commissioner Stan Vanderwerf to close us out and ask if there are any other comments. So I'll let you close us out. For those of you who desired to make public comment, please email me, and we will also be having further meetings, in which case we will be sure to include public comment time. Thank you very much, Mr.
Yes, thank you, Jody. First of all, I want to thank the citizens that came in and testify. I knew it was hard to do that, but I thought that was great, and it's important that you have a willingness to speak up. So thank you for that. And I also express my appreciation to everybody else that's here. We've got a lot of resources involved in this, and it's really more a question, I think, of do we have the right resources? Do we have enough resources? Is there something we can do? This is, notwithstanding you have someone in a nursing care facility or in some type of senior home, and it's tough. And I'm facing the same thing as I mentioned earlier. My mom was in that situation. But what we need to do is we need to figure out what can we do or try to do to try to affect some change to get the services to be more efficient or better directed, or whatever the situation is. And I do respect the time that we have here. We could probably go a little bit past 10, but we were planning on ending at 10. And literally I have to leave not long after 10. This is kind of amazing. I'm literally driving to Denver to go to my confirmation hearing for my appointment to the Colorado Board of Health, which is the board for CDPHE, which is part of the engagement of what's going on here. And just a quick point on that, and then I actually want to open the floor for suggestions. Even though I've attended a couple of the CDPHE meetings so far, and in my first meeting, which was in January, fentanyl is another big issue, and I asked that could we take up another meeting on fentanyl, and CDPHE agreed, and we're actually going to take up a fentanyl discussion in the March Board of Health meeting. I'll bring this point up because maybe I can make another suggestion about senior facilities and maybe take that up in CDPHE and see if we can have maybe a similar discussion like we're having here, but at that board. And there maybe I could maybe offer to bring some citizens up there to testify at CDPHE, and Jody, I can work with you on that. But and later today, I'm just doing the confirmation hearing, but when I get into a board meeting, I can maybe bring this up and see if we can start to have a discussion there. I'm sure they would appreciate, those of us that are out here working on some of these challenges, and maybe see if there's something we can do with them to make this process better. Okay, having said all that, I heard, staffing, supervisors, inadequate training were some topics. And so I'd like to open the floor and see if anybody has suggestions. I'll start with one, and I don't know if it's a good idea or a bad idea, but it was something I thought of while we were going through the discussion. Is there a way that we can help better train families that are being challenged by this? Some kind of family training. This could be an individual or a family, so that they know what their rights are and what their obligations are. And we probably have that already. Well, maybe I'll take that back. I'm sure we have that. But is there something we need to do or could do in that arena? So I'll open the floor with that, and then I'll just see what other suggestions other folks have. Go ahead, Mayor.
Yeah, we have a legislative committee through PPACG with a lobbyist, and I want to make sure everybody is aware of two bills that are going through that that are in the bill stage right now. This is something you can do. The first one that seems to be gaining what we call legs, that means it's moving along, is Senate Bill 22-053. It's concerning visitation rights at healthcare facilities. We really need you to call anybody you know up at the State House. There is only one Senate sponsor and one House sponsor. At this moment, we need bipartisanship sponsorship on these bills. So if you know people, we need to get them to sign on. This bill specifies a patient admitted to a hospital for inpatient care and a resident of a nursing care facility or assisted living residence may have at least one visitor. And we all know how that got chopped off during COVID. And so that's a bill we need. There's also a second one that's very similar, House Bill 22-1199. It also has to do with visitation requirements at healthcare facilities. Again, we need sponsors for these bills. We need them to move through. This is not a partisan issue. It cannot be a partisan issue. This is a people issue. And the people need to push, right? We're the government of the people, by the people, and for the people. And we need to push these bills through, because we saw during COVID, family members did not get the care. Unfortunately, I've had family members and friends for over 30 years in and out of these facilities. The stories I am hearing today are not new, not different. Very, very similar to what I think we've heard for over 30 years. And we need to do it. And it's not just seniors. Any one of us at any age today could end up in a long-term care facility for any reason. I had an extended family member just passed away less than a month ago. Kidney problem popped up, could not get transferred to another place that could handle him, and he passed away. So it is happening. It is real. So please work on these bills, make your phone calls, send your emails. Don't send a form email. Just a couple sentences, please support this bill. It's important that we care for our people. So, and write your council members and make sure your councils are on boards with supporting these bills and putting their city weight behind them too. So that's just something that we can do today. So
Great.
A lot of these things are, in the future, but that's something you can do today. We need to get visitation through and get the people back in these facilities so we can see what's going on. We all know the person that gets the visitors gets the best care. I mean, that's just reality.
And hopefully the COVID issue will be a transient issue, but it's probably why maybe the number of reports have gone down, because less family members have been able to see their loved ones in these facilities. So there's less observation going on. So that might be actually an indicator of that issue, right? So one of these, Senate Bill 22-053, you might want to write it down. And what was the other bill? And then once we get
Bill 22-1199.
Is that Senate bill or House bill?
So Senate Bill is the first one, 22-053, House Bill 22-1199, both similar, but maybe if we push both, we can get one through, right?
Okay, great. Thank you very much. Yes, sir. Go ahead. Suggestions.
Yeah, I like to then reinforce the statement you talked about, people being orientated or have knowledge about what you can do or identify the different medical problems that their loved one has. I personally, my father-in-law, I had to become really proactively involved to find out what, where, and why. And then when I did, I actually removed him from that facility, and the people that were involved with that were actually charged, and we went after them with full force. This is an emotional type of statement, but I think that the people, when they put their loved one in that home, they need to know what, where, and why. Okay, and you are bombarded with a ton of paperwork. Okay, and you have no idea about what, where, Are you kidding me? Okay, and then whenever it's almost too late, like when Warren, when it was almost too late for him, that's when we had to take our action. So, okay, I think this is something we need to kind of push forward to make sure that these facilities let the loved ones know what's going on.
Great, thank you. So I think that's a reinforcement about, some training for families. And to be fair to that, I had some discoveries myself. I didn't know that there was a law that requires 24-hour reporting of abuse. I think if I were to see abuse, I'd report it anyway, but I didn't even know I had a legal obligation to do it. So I think that's a pretty good indicator about training needs. And maybe a piece of that should be annual training for this board. Just so that we always know, and when we have elected officials come and go, maybe we need to have that as well. But you had your hand raised, you probably have a comment to this. Go ahead.
So the Ombudsman's office would be happy to provide training on resident rights to any community member that is interested in receiving that training. So I want to put that out there. And I also want to point out that we've heard from APS and prior law enforcement about some really serious work that they do. I think they're underfunded, undermanned, and CDPAG as well. And so we have all of these services that are put in place to assist residents in long-term care and to keep them safe. And our role specifically as Ombudsman is resident rights. And we're still failing. So I'm really looking forward to just further discussions as we go forward on how we can look at things a little bit differently. So those are my
Thank you. I think, Jody, we've got a couple of comments there. One is about training, and that might be a little bit of training about our board, maybe once a year, something like that. And then is there a way we can figure out how to expand? Because I'm sure you have it, you just mentioned it, right? But is there a way we can figure out how to better train, family people out in the community that need it? And then there was another point about maybe a deliberative discussion in the future about funding requirements if there's shortfalls. I think, do we have a hand raised? Yes, ma'am. Oh, Mr. Zulaga, please go ahead.
Yeah, I'd like to offer a perspective and a possible solution, a little different direction. Culturally, we've moved away from having extended families. So having our elderly living with us in family. And so that's moved us into care homes. A friend of mine was working with a large care home facility across the country. It was about 300. They had about 300 facilities. It was run like a family. The guy who owned it treated his staff like family. They'd go away on vacations together as family. And so when they got to the work environment, they were all committed. They were committed to that whole family sense. Well, the guy passed away, and the family, the sons, daughters, whatever, sold these 300 facilities to hedge funds. The quality of care immediately tanked. So now you have people who don't care in the facilities. It's just a job. It's just a paycheck. So what I would offer as a suggestion, as you go to the health department, you look at what are the ways to improve this systemic problem. What if there's a way to incentivize families to take on elder care in their family home? What if there's a way to incentivize the family model in the care homes? Maybe there should be a distance between corporate. Free enterprise should drive the bus. Government shouldn't drive the bus. And what if there's a way to incentivize free enterprise in these care homes to perform like a family so that these people are truly cared for, rather than thinking we just throw a bunch of money at a system that's decaying or corrupt? That's not going to solve it. No amount of money, we're seeing it everywhere. People want a job, but they don't just want it for the money. Some people want it because of there's other benefits to it. So we're in a changing time. I think COVID has highlighted that. And I would just encourage us to look at family solutions and incentivizing that part of it as we move forward.
Yeah, thank you, Mr. Zulaga. We've certainly, I agree completely, and I'll get to the other comments in a second, or the other hands raised. our society's been changing, right? We used to have extended families, and then you could have, 3 generations in a house. And that was a pretty good model about taking care of people that were in the family. And we've moved away from that, and it's harder now, right? But there is no better motivation than the family members themselves to take care of their loved ones. So I like the idea, and I don't know what the answer is, but is there a way to support families so that they can have a stronger engagement, maybe even in that senior person's house? And there'll be cases where the family won't know or have the capacity to deal with all the issues. So this is about, getting professional care in the home. I can tell you that is exactly the question I'm dealing with my own mom, is bringing her to a senior home, an institution of some type, or hiring some type of nursing care for her at her house. And then there's questions like, should that be 2 hours a day or 4 hours a day or 8 hours a day? And, what are the costs about all of those kinds of things? But that is, I think, another option. And I think we should explore that. And let's leave that alone at the moment because we've got other hands raised. I think we've got a hand raised online. I don't know who it is.
Can you scroll back to the question that was Councilmember Henson?
Oh, okay. Councilmember Henson, if your hand was up.
Fortune.
Oh, Councilwoman Fortune, I think you had your hand raised. Please go ahead. Okay.
Sorry, I didn't have my hand raised. I was just wondering if there was a database similar to the National Practitioners Database, data bank that family members could access to get into that education and knowing what is a good or a long-term care facility that's had lots of problems, just to help make for their decision-making. Thank you.
I think that's an excellent question. It kind of revolves around, is there a way for a family member to evaluate healthcare facilities for their seniors so that they know which ones maybe have a good reputation and which ones don't?
Lori.
So there is a tool on Medicare Compare that people can use to look at the most recent surveys. Although in using that tool, we often suggest to families that it not be the only tool that they use because it's based on one snapshot in time of a facility. So a facility may have had a survey that was a poor survey or a good survey, but that was just in that one snapshot. So they need to really go in person at an unscheduled time and not talk to the sales or the marketing person, and go to every single floor or every single wing and actually talk to the residents and observe things. So, and again, on the National Consumer Voice website, there are some articles and information on about what to look for in a facility. So that's probably more of an answer.
You can also get on the CDH,
CDPHE, Colorado Department of Public Health and Environment website.
and they have, and when you look up there, you can look up the direct facilities and you'll see every complaint, every violation they've had, every correction that they've had as well. And then that'll kind of go through that with you.
That's great information. So Jody, I think that's another thing to take up, right? That's a little bit about empowering citizens with knowledge by giving them resources, some of which may already be available. So it's a matter of them being aware of it as opposed to trying to create something new, but that can be a topic. And Andy mentioned to me that Jarrett Hughes is from the governor's office and he's online and he's had his hand raised for quite some time. So Jarrett, if you might, you probably have some comments you'd like to make. Please go ahead.
Yeah, no, I appreciate that. And appreciate you all pulling the conversation together. I think, I want to give some credit to Pikes Peak COG and the Area Agency on Aging. And especially, I know I've worked with Jody over the last few years, and as well as Melissa Martz with the COG. And I think one of the issues that I know we have seen in long-term care is kind of the proliferation of complex medical and behavioral health needs. And so that's one of the areas I think we really do need to kind of take a significant bite out of. And it's an area that I think we are committed to working with the Department of Public Health and the Department of Healthcare Policy and Financing on as well. And so I also wanted to recognize the comment, and I apologize, I was having a tough time hearing, but I think it was Mr. Zulaga, and I apologize if I get that wrong, but just mentioning kind of the importance of, I think, the state and local governments working together with industry on this, because like you said, we should not be driving the bus on this, but the state through taxpayer dollars and our federal government are significant payers in this space. So we do have a lot of accountability and oversight responsibility here with our taxpayer dollars. But I think on our end, very committed to working with industry on what solutions can be, because over the years, what we've ultimately had has been a very kind of punitive approach to long-term care. And I think even if you read the link that Leah posted from the White House on Monday, there still is kind of that penalty-oriented language. And I think we really need kind of solutions-based policy here. And I think we have outdated payment models. We have payment models that have not incentivized innovation or kind of new models of care. And I think now is obviously the time for us to be having these conversations in this focus. So I just wanted to share that kind of broader perspective that this is something that we are talking about and thinking about, and I'm going to elevate this in my senior staff meeting later today. So I just appreciate the partnership, and I'll also give a shout out to Representative Mary Bradfield and some of the work that I've been engaged with her over the last few months. So just wanted to thank you all for the opportunity and for pulling the folks together, and looking forward to more of it.
Thank you, Mr. Hughes. There's plenty of content in your comments, and I appreciate those. But the one that I have specifically as a takeaway is, can we do some benchmarking? Can we look for other models that maybe are delivering some success? Maybe see if we've got some of those going on in Colorado, or is there a way to approach this a little bit better? There was a concept in there of payment models, but also a concept of maybe forms of innovation. It's a little bit maybe, are there models where, family members can do at-home kind of care, so that's a really, really broad topic and something that probably will take a much longer time to address. And I would imagine that our own agency on aging has several ideas there. So we'll have to reserve that for another day, but I think that's something we want to address. I think there was Councilwoman from Fountain that has had her hand raised for some time. So if you might come forward, thank you.
Okay, thank you, and good morning to everyone. My interest here today is my undergrad was in human nutrition and food, where I obtained my degree in, I'm a registered dietitian. And I have worked in long-term care here in Colorado Springs for some time before I had my son. And I've worked at a lot of different agencies here. And one of the things that we implemented in one of the long-term care facilities that I was the initiator of, that I carried with me, was to caregivers and to family members, were to bring pictures of your family member when they were younger and where they worked, and where they were a nurse or they were a teacher. And that way, when the CNA or whoever came in to take care of the family member, they had pictures of them when they were younger, where they saw them in a different state other than just needing to be helped. They were once workers. They were once like you and I, able to take care of themselves. They lived in their own homes and they were out active. They weren't always in need of care. So I just wanted to put that out there that that helped really well. They walked in the room, maybe they even saw that this was once my first grade teacher, and I'm going to take care of her, that incentivized them to take care of them a little better.
Thank you very much, Councilwoman. And I know that we've got a lot of great comments online. I think I see one from Nancy Fortin, but we've missed we've missed the opportunity to state several of the others that are earlier publicly here, but this one is the accessible housing movement would be appropriate to partner with as they're looking at, as we are looking at creative solutions to successfully age in place. But I'm certain, Jody, that you'll capture all these comments and there'll be some, maybe some courses of action that can come out of those comments as well.
I would also ask if you're here in the room, making sure that you sign in so we can capture that you were here and provide contact information so that we can make sure that you're invited to our future meetings. Just want to capture that as well. So.
Okay, and Mayor Thompson, just a second. I think I saw some other hands raised, but I'll make sure that you have an opportunity to comment as well. Did I see other hands raised that wanted to discuss it, to talk at this point? And Darcy, I thought you had your hand raised a while ago. Are you good? You were just trying to make sure that the council, okay, great. Go ahead, Mayor.
One thing that's been brought up today, and we talked a lot about staffing shortages, is this spills down to people who are taking care of their family members at home. My mom was at home till the day she died, in my home. One of the last months, we had 17 different caregivers through an agency that was supposed to provide us with 2. And they sent 17 different people within a 4-week time period, of none that were now familiar with the case. It's exhausting to the families. I understand exactly what Shannon said. You want to just talk to your mom. You don't want to have to be in the bathroom with her, helping her clean up. You just want to spend time with your mom. You don't have that time because you're exhausted. And the reason I had so many caregivers, though, is they contract with these facilities to try to fill in for them. And so their higher priority becomes the contract for the facility rather than the patients that are in the home. I never heard anybody else. I didn't know that until I fell into this. And I found that with multiple agencies, we probably went through. And if you raised the concern with them, you got fired because they don't want to hear complaints from their patients. And so you moved on to another agency. And so that is just something I think that needs to be brought in the conversation of it spilling down into home care and causing issues.
And I need to step away just for a minute. So if you could maybe pick up the meeting, I think we've got public comments still, but I'll be right back.
Go ahead, Andy.
No, I'm just going to say, Kent Matthews runs our Family Caregiver Support Center. So maybe just briefly, he can build on that comment that you made, Madam Mayor.
Hi,
Mike on.
My name's Kent Matthews. I oversee the Family Caregiver Support Center here at the Area Agency on Aging. The issue is broad and complex. What you said is very common. The Bell Policy Organization just put out a white paper saying that by 2030, there's going to be a shortage of paid and unpaid caregivers of 115,000. So the structure that we have always from generation to generation of family taking care of family is not going to be in existence. That backbone is going away, and it is not going to be there. Other statistics I have seen is that by 2030, for every family that needs family members to care for them, the ratio is going to be 4 family members to care for the 1 family member. By 2015, when all the boomers are 80 over, that care ratio goes down to 1 to 2. And right now, there are not enough people because of, for a lot of different reasons, whether it's hospitals, rehab facilities, care facilities, home care agencies, they cannot hire enough people. People are not applying for those positions. There's a lot of reasons why that's going on, which it creates 17 different people. That doesn't help. But we can't rely on family members, adult kids, grandchildren, whatnot, to step in to fill that void because they're not going to be there. And so we've got to do a lot of very creative, out of the box thinking in terms of how to do this. And we have to, yes, find ways to incentivize. But the other thing is we have to go back and start realizing that these are these are people that we are caring about. This isn't about money. This isn't about paying people. It's about taking care of each other and getting a sense of community back in terms of caring for our neighbors. And so I agree with the different approaches, but everything has to be put on the table to take a look at this. And because the family members that we've always relied on for the last 30, 40, 30, 40, 50 years are not going to be there to even visit their loved ones in the care facilities. They're not going to be there. And that's, this is a very complex issue. And I talk to a lot of hurting caregivers day after day after day who are exhausted, overworked, and they don't know where to go. And there are no easy answers.
Thank you. I appreciate that. And I can tell you that I know that there is frustration in the caregivers as well, because they care deeply and they do have trouble doing everything that they need to do or can do. And just as a point, in El Paso County, we have 10,000 unfilled jobs. Actually, I think I heard maybe from the Pikes Peak Workforce Center, maybe it's 20,000 unfilled jobs now. And about 1,000 or 1,500 of them are in the healthcare services. So every industry is very short of people.
That's a perfect segue, Commissioner Vanderwerf. I would love to introduce Penny, if you wouldn't mind sharing just a couple of minutes. Penny Whitney has been across the state and our local area talking about workforce issues. So please, thank you for being here today.
Thanks, Jody. My name is Penny Whitney, and I'm here today representing a state group, the Direct Care Workforce Collaborative, that is intentionally focused on addressing staffing issues across the continuum. It's a home health care issue, it's an assisted living issue, it's a skilled issue. It is across the whole continuum in Colorado and also the nation. I know we're short on time today, but very, very encouraged that this is the beginning of a conversation, not the conclusion of a conversation. And as the co-chair of the Colorado Direct Care Workforce Collaborative, I want to offer our support to be at that table with you. And I know El Paso County has a number of initiatives that are going on in terms of recruitment, retention in the long-term care spheres. So it is complex. There are people that are willing to be at the table to help because, as Kent said, the trajectory of need is going up, the workforce is going down. That is not sustainable. So thank you for the opportunity to be here. Thank you.
Can you give us your contact information, please, ma'am? Ma'am, can you give us your contact information?
You know,
Into the
actually, if
mic.
you'll give it to Jess.
Okay.
Yeah, perfect. She'll share it out.
And if we might, Jody, we do need to close up. I've got to go myself, but since this is a formal meeting, because we have a majority of board members present, we do need to make the offer for public comment. It's on the agenda. So I want to do that right now. We may have gotten through everybody already that wanted to offer public comment, but let's make the offer. Is there anybody else from the public that would like to comment on this agenda? Yes, please, ma'am, go ahead.
I just had one comment in regards to, caring for your loved one at home. That is obviously something that my family would love to have the opportunity to do. However, my stepfather currently works. They also care for my 13-year-old nephew. I work full time, and the care my mom requires is 24-hour care. But one thing that I have experienced in my personal situation is that insurance limits and dictates a lot of the care that your loved one can receive. And one area of that, which has been extremely frustrating and disheartening, confusing, the skilled nursing aspect. With her insurance, Medicare, TRICARE, she's allowed up to 100 days of skilled nursing rehabilitation. However, I was warned by several individuals that it rarely ever hits that 100-day mark. I don't understand the rationale behind something like that. I imagine that rehab can only benefit a patient, even if it's just a matter of getting them out of bed. But especially the physical therapy, occupational therapy, speech therapy, in my mom's case as well. To limit that, or to even say that they can't even maximize the benefit blows my mind. And in my experience at the facility my mom is at, when I called a family meeting early on in her initial arrival, I was told, that, she has to continuously show progression but they're not even performing the therapy to the bare minimum, let alone giving her an opportunity to continuously get, more independent. And then she's having these severe infections she's fighting, and all of a sudden their baseline, whatever that is she's plateaued. She has to be moved over to long-term care. And this was like 3 weeks in, not even a month, let alone 100 days. And the way the facility explained it is we have to continuously meet this criteria to explain that she is continued progressing. However, they're not even doing their part in ensuring that she is. And why wouldn't that make their job easier, and maybe even give her get at a potential phase where she could leave the facility and go home and be cared for by her family members? But we won't even know what she's capable of, because instead she's regressed. She can't, she was at one point able to sit on the edge of the bed, stand up with assistance, kind of formulate a wheelchair with one hand. She can't do any of that now. So plateauing is one thing. That should be where she at least maxed out. She's completely went backward. And so I don't know how much the facilities are leaning on this insurance factor as an excuse. Yeah, the 100 days doesn't seem nearly enough to me, but she didn't even get that. And they kept using that as, oh, well, we have to continually prove, but they're not even proving to us as a family member what type of therapy has even happened. There's no communication there. So it's very disheartening, and insurance is a whole other beast. And I understand that. And it's unfortunate that it does unfortunately dictate care on a lot of levels for a lot of different things, but the facility shouldn't be able to have that out. They should at least have to maximize that 100 days. And I don't understand the reasoning as to why they're even able to not do that. So that's just a statement more than anything.
Thank you very much for your comments. Well, we've got some board members that have their hand raised, but just a second on that. I want to just conclude that we have reached out to every member of the public and make sure we've completed that, since it's part of our meeting agenda. So thank you for those comments.
We have one more.
Okay,
I can't
please.
see past the post. Melissa, is Sharon still here?
I don't know.
Okay, okay. Go
Please
ahead.
come forward.
I'll just echo what everyone has said already in terms of just pulling this conversation together. I've been with Silver Key. So my name is Dayton Romero, Director of Healthcare Strategy and Integration at Silver Key. I've been with them for almost 7 years now, and had the opportunity to collaborate with many in the room. And part of our mission is to allow people to age with dignity and independence. And we've been big advocates on the elder abuse sort of realm. So what I just want to bring forward here is Silver Key is offering its support through education, in which we're integrating it within all of our staff and volunteer training. So we're serving 9,000 seniors annually, and have 600 volunteers, 70 staff members who are all educated and receiving training on mandatory reporting. So we're equipping, using that as a capacity and education builder. And through guardianship, I want to bring a sentiment forward that was talked about of those without a voice. In guardianship, we serve individuals who don't have the ability to make their own decisions. And so we've seen it and lived it, where those who have a voice for them or advocate for them are receiving the most care. So I just want to offer my support. Our Silver Key will be at the table with that. And as another representative for the Colorado Elder Rights and Abuse Prevention at the state level, I'm chair of that coalition, and we're working hand in hand with the State Unit on Aging and exploring ways how we could get education to the entire state on relevant issues and what we're seeing in the field today. So CCERAP, .org is a website and a resource for archive trainings on many issues that we've talked about today, and will continue to be on the pulse of. So thank you.
Could you go over that? Yeah, right.
Okay, and Commissioner Vanderworth had to leave, so I'm not quite sure where we are with hands. I do see Mr. Zululaga. I'm going to
Nope.
ask
I'm good.
people to keep your comments really short. It
No,
is
it's okay.
almost 10:35. Okay, your light's on and I thought I saw your hand. So, okay.
Mine is real brief. We need more communication. Positive communication makes positive results. Okay. So right now in my rural area, we have a lot of in-home care and a lot of those people are asking me questions and I'm going, what? Okay, so I'm going to become aware of what, where and why, but my point is we need more communication.
Yeah, and right now, while we get that going, just please, anybody you talk to, refer them to Jody and he'll get them to the correct person that needs to go to. Andy?
Just real briefly before we start wrapping things up, we are going to have this on the board agenda, our regular board agenda for next Wednesday to keep the conversation going. What I'd like to do is have us work up the list of all the good ideas, the next steps and other actions that we talked about today and get those in front of the board. And we'll strategize internally. Lori, Jody, and I will figure out how to keep the momentum going. Obviously, we've gotten everybody's attention. And we always put ourselves out there as being an age-friendly community, an age-friendly region. So let's walk the walk and really kind of set the standard.
Okay, can staff members stay around for or just a few minutes for people in the audience that might want to talk with you or give you contact information? If you have to leave, I completely understand, but maybe that's the way people that have spent a lot of time here today with us but haven't had a chance to talk. I'm willing to stay around till about 11 if people want to talk to me. But I know the staff, you guys are the pros on this. So
I would encourage other staff who are able to stay to stick around. If you'll raise your hand, I see Kent, Melissa, Marky, Lori and I. Gretchen, are you able to stick around for a few minutes? Okay, great. So we will stay in the room as long as we need to this morning. Thank you very much for allowing us to both share impromptu at the last board meeting and then continue this discussion on a community-wide. And obviously now we're moving up through the ranks beyond our region and to the state level. So thank you to all those who joined us today by Zoom, as well as the opportunity to share today. Thank you.
And there is one action item on there. It says letter to CDPHE and governor's office. Is that something you're going to bring to our meeting as something to potentially approve to be sent up?
I think so. We'll brainstorm on that a little bit. That was just to kind of get the ideas going. Really wasn't necessary. There are plenty of other ideas, but we'll noodle on that a little bit and may bring that forward next week. Yeah.
All right. So thank you, everybody. Oh, Darcy, did you have one last thing? I'm sorry.
So I just wanted to say something to you and to everyone here. Thank you for your comments about rehab and level of care discrepancies. As a former clinical analyst, my job was to argue, to be the arbitrator between denied claims by the insurance company and to get those claims paid. And so I am very familiar with how staff members can use Milliman care guidelines, interqual criteria almost as an out to perform the level of care that the patient needs. And I actually see, I know we don't have a lot of time, but I think there is room for some education in these facilities to use such guidelines to the advantage of the patient rather than using them as a disadvantage to the patient. If staff members work hard enough, if nurses and LPNs, if they appropriately document everything, which is again something we talked about today. If the documentation is there, if the physician's notes are constantly there, then using these guidelines and using those criteria to help the patient and to get them more care rather than less care is possible. So I think we need to have some education on that. I don't believe that a lot of people that work in these facilities are familiar with how to do that. And I think that that's something that we can do to kind of stand up to these insurance companies.
All right. Thank you very much. Wish I'd known you about 10 years ago when I was fighting through all that. I have almost a master's degree in fighting with insurance companies. All right. Well, thank you everybody for coming today. And I really appreciate it. Appreciate staff being willing to hang around for anybody who has any questions. It's a huge issue. I think we'll keep moving forward on this. Thank you. All right. Do I have to adjourn this since it's kind of a more, okay. We're adjourned.